right after a stroke. Sometimes I've seen a person where they aren't able to say anything at all. They're having a hard time, even answering yes or no questions, understanding anything. And then you might go back 2 days later and they're talking again. I didn't do anything, right? That was just the brain, the amazing things that the brain can do.
Welcome to In Good Company.
So Molly, tell us about yourself and what it is that you do.
Yeah. So I am a speech language pathologist. I work at Mercy Hospital in acute care in the main hospital. I previously worked in outpatient for 3.5 years. So I work just with adults primarily. So I get to see a wide range of, diagnoses and ages, whether it be neurological stuff like, strokes, brain injuries, or, a lot of just, aging, things like dementia and then I get to see some like younger people as well. So it's just a very wide range.
And what brought you into this line of work?
So, when I was trying to kind of figure out what I wanted to do, I thought about, being a teacher or, doing healthcare. And then my sister-in-law was in school to be a speech path, and she kind of told me about it. I started doing research and I realized that's like the perfect in between of the two. And then around that same time, I also had an uncle who had just had a really major stroke. And he was, talking to me about everything that he went through and talking about all the therapies he did and everything. And I told him, I'm actually thinking about, becoming a speech pathologist. And he got so excited. He was like, the speech therapists were my favorite. Like they helped me so much. And so, that was cool. It kind of solidified, for me that it was a good area to go into.
What does your typical day look like?
So now that I'm in acute care, I get to the hospital and, I might spend the first, 30 minutes to an hour just looking over my list of patients for the day, doing some chart reviews, figuring out, what's going on with every person, what they're going to need, and then just going out and, hitting the floors, seeing all the different patients. And so, I would say the two biggest things that I do in acute care are swallowing and cognitive evaluations. And then we do also do a little bit of treatment on the acute side, but it's a little bit less frequent because obviously with it being at the hospital, there's constantly patients ebbing and flowing. And so, we kind of have to triage. We have to, prioritize like new patients, patients who are currently NPO, so not able to eat or drink by mouth. So it's different every day, which I really enjoy about it.
And I'm just curious, what are some of the misconceptions you might face with speech pathology? People may not understand.
I would say, like I said before, like that, first of all, that we do a lot more than just speech, I feel like if they could rename us to like speech, swallowing, cognition, all these things in the title, it would probably be a little less confusing, but that would definitely be one misconception. And then, people are really surprised, I think, whenever they learn that we are the kind of swallowing experts and specialists. So that's definitely a big thing. And then within that, there's definitely a lot of misconception. Like I think about with swallowing, the biggest thing is just understanding, aspiration, which is, the kind of the biggest thing that we tend to worry about is, people having liquid or food go into their lungs instead of down to their stomach. So, but there's a lot of misconceptions about, thinking that, if I cough, then I aspirated. And if I didn't cough, then I didn't aspirate. When in reality, there's silent aspiration. So you can aspirate and not cough. And also sometimes people cough for reasons other than their swallowing. So so you can't really tell just by watching a person eat a meal, whether or not they're aspirating. So we actually do a lot of imaging as well. We do modified barium swallow studies, which are functional X-ray studies where we watch a person swallow food and liquid to see how things are going down. And then some people also do what's called a FEES. So that is where they go in with a scope through the nose.
Okay.
And that's how they kind of see, they watch the person swallowing from that angle. So
you work with both outpatient care and acute care. What are the differences between those two?
Yeah. So outpatient is more of, I'm going to go to an appointment, right? I have a scheduled appointment that, I'm going to either drive to or someone's going to take me there to a clinic. Generally speaking, you're probably going to see those people, maybe once or twice a week. So you're going to be seeing the person, several times. And with outpatient, it is, you typically get people who are, they have to be motivated to do it because it is, definitely a choice to do that. And then with acute care, you're seeing people in the hospital. So you're seeing a very wide range of people who may or may not be interested in therapy. Sometimes they don't want to do that. And, of course, that's every person's, decision and right. But, we just have to come in and kind of help them through that initial stage of, I just had a stroke or I just had, some type of accident or injury that's causing problems with my swallowing or, my memory and thinking. So that's kind of the main differences.
And for listeners at home, when should you see a speech pathologist? Like, what are the signs where it's like, yep, that's who I need to speak to about my condition?
Yeah. So any type of swallowing issues, whether that be you notice that you're coughing during meals, if it's, I feel like when I'm swallowing, things are getting stuck, and that could be you're having trouble with liquids, solids, pills, all of the above. If you are having trouble with your memory or thinking, whether that's a new thing or it's been going on for a while, those are some of the main things. And then, you think of the things that people tend to think of, which is speech. So if you're having speech changes with your speech, your voice as well, that's something that I personally didn't do as much of, but there's really great outpatient therapists that specialize in voice. So let's say your voice has gotten, raspy or quieter, and that happens a lot with aging, weaker. Mm-hmm. You're having a hard time being heard, anything you could think of that is changing with your voice. That's another time that would be good to go see a speech therapist.
And what does a typical session look like?
So it really depends, thinking about like my, current state being in acute care, whenever I first walk in to see a patient, I'm introducing myself and, what I'm there to do. I'm going to first start by just talking to the person and just finding out, from them, what's going on. If it's swallowing, I'm going to say, have you been having swallowing problems before this, or is this a new problem? Just kind of getting, all the background information. We do what's called an oral mechanism examination. So that's where we're trying to look at how all the muscles in the face and mouth are working, and as well as the nerves. So you have people like make faces at you and do different things. And a lot of times people look at me really weird. And I'm like, I promise I'm doing this for a reason. So, there's that. I give a lot of people things to eat and drink and just, watch how they do with it, make observations based off that. And then, talk to them about my recommendations, whether it's, I think we need to do some imaging to get some more information, or I think you're probably okay to eat and drink right now or whatever. But, also at the end of the day, my goal is to, educate the person, but then also, it's very important to make it known that, it's at the end of the day, it's their decision on, what they want to do. So, I might have a recommendation based on the information that I have and, my expertise, but it doesn't mean that's what they have to do. So in the acute care setting, that's kind of what it looks like. Or, on the cognition side of things, same thing. I'm going to get, background of, what's your home life look like? Do you have any problem? Are you independent with your, day-to-day, activities of daily living? And then, are you having any trouble with any of those things? And then, I'm asking questions to find out, how oriented they are, to kind of, where they are, what's going on, kind of that basic stuff. And then with cognition, we'll do what's called a cognitive screener. That's in the acute setting. If you're in an outpatient setting, or even like, rehab, they will do more extensive testing, because they are, they kind of have a little bit more time, to spend with you. So, but we're just, we're doing a test to kind of figure out what's your baseline. And then from there with cognition, it's, if in the acute setting anyway, do we need further therapy? Right. And if we do need further therapy, we may be able to see you while you're in the hospital, but it's one of those things where unfortunately we don't always get around to it because you're in and out so quickly. But we can make those recommendations of, hey, I think you'd benefit from doing some rehab after this, whether that be going to an inpatient rehab or a skilled nursing facility, or, hey, I think you'd benefit from some home health therapy or outpatient therapy. So just kind of getting them started on that path. We're kind of the, step one, I feel like.
I know we touched on this briefly, but when people hear speech therapy, they often think about just only talking. What are some parts of your work that might surprise people?
So, kind of already mentioned like, the swallowing aspect, and that's a really big part of what I do. The cognition, so memory and thinking. I also, personally have had experience with working with patients who have had a laryngectomy. So they've had their voice box removed, which is kind of more niche area of within speech therapy. But, those are people who sometimes they have a voice prosthesis and that has to be changed out. And so that's actually done by a speech pathologist.
Wow.
It's a procedure that we do. So I think that's a big one that would probably surprise people. Cause it's, I mean, I don't know if this is the right way to say it, but I feel like it's a more medical side of thing, more, everything that we do is medical, obviously, but, just that procedure in and of itself, I think is something that would surprise, people that we do. And I think too, the imaging, the testing that we do, like doing scopes, doing, like I mentioned, excuse me, before the modified barium swallow studies, like the x-rays. So yeah, I think there's a lot about what we do that, when I tell people, they're like, whoa, I would have never thought that you would do that. So.
And for listeners at home, what are some signs families should watch out for if they're concerned about a loved one who's swallowing?
Yeah, I would say a big one is definitely coughing, coughing during meals, coughing after taking drinks of liquids. That can also be not necessarily coughing, but throat clearing. If you notice your loved one takes a drink and then they always go, right? It doesn't have to be anything. It doesn't have to be this huge like coughing spell necessarily. So that can be one. And sometimes people don't always notice it themselves. So it is definitely important for, loved ones to, say something if they notice those things. If they notice that the person is, losing weight, if someone is having recurrent pneumonia, that can be a sign of a swallowing issue. If it is related to aspiration, if they're saying that, things feel like they're getting stuck, they're not able to eat a whole meal, like they may only get through half or less of their meal, that can be a sign too that, either things are getting stuck on the way down. Sometimes too, we can be the ones to refer somebody to a GI specialist if, let's say we do our testing and, the esophagus is kind of the lower part of the swallow. So we do see problems with that. And we can help in some ways with that. But sometimes we also need to refer those folks on to, a different specialty, which is usually a GI, gastrointestinal doctor. So yeah, I would say those are the main things that, if you notice that, to say something.
Can I ask one question?
Yeah.
Because I've heard this over the years, and I just want to make sure that it wasn't a myth. But I've heard that if otherwise they didn't have like watery eyes or runny nose, and they consistently, every time they eat, all of a sudden it seems like they have more problems with that. Is that also a sign? Or is that not, have I always had that wrong?
Yeah, that's a great question. Historically, that was a big sign that they looked for. I'd have to do a little bit of research and looking into that, because it's something that I've seen more recently talked about, where it's like, no, that's not necessarily a telltale sign.
Okay. That's good to know, because that's updated since,
For sure. Yeah. Yeah. But, I think it's one of those things where it could be worth noting, if it's like, if they're, any type of change that a person is having, like during a meal, or if they're like having, maybe they are, swallowing, and then all of a sudden, like their breathing sounds really, congested, or they seem like they're having to work harder to breathe. Those types of things can also be a sign of, aspiration or having some trouble. So yeah, great question.
Could you share with us some success stories?
Oh, success. That's like, it's hard. Like, I know I've had a lot, but it's, it's one of those things where you're like, okay, now I have to think of a specific one. I think in outpatient, I was able to see things through a lot more with people. I really enjoyed working with patients who had a stroke and had something called aphasia, which is a language problem. So that's when a person has trouble with speaking, understanding, reading, writing. So it's not the cognition side of things. It's not like, memory. It's more of the language side. And those patients a lot of times can make really big you can see really, really great improvements. So, I definitely had times where, you'd be starting out with someone and, they could barely, tell you their name or what happened to them. And then by the time, you're done working with them, they can very easily communicate. And even if that's not through, verbal communication, there was something that I, had become kind of passionate about for a while too, was an outpatient was, finding alternative modes of communication, for people, especially with aphasia. So, it can be a device, an AAC, alternative and augmentative communication. So those can be really, really, helpful for people in their, functional communication, day-to-day lives. And then, it doesn't have to be a device. So it can be, as simple as like writing things down on pen and paper. It can be using your phone to help you communicate. It can be having a picture board, with different things that a person can point to.
Can I ask, what are the main causes for aphasia?
Yeah. So one of the main causes is a stroke. So that's probably the big one, but there are other things that can lead to aphasia. And I think that's probably a myth when it comes to aphasia, is that it's just related to a stroke. So it can be, a brain injury. It can also just be, aging. There's something called primary progressive aphasia, which is actually kind of under the umbrella of a type of dementia, but it is affects more of those language centers of the brain. So yeah, really anything that is impacting the language centers of the brain can lead to aphasia, but most typically we say it was stroke.
And the people, because you say they have. You have good progress with some of them. Where do they attribute that progress from?
a lot of times they can really make a lot of progress in the first like 6 months to a year. And some of that is the neuroplasticity. So just the brain's ability to kind of, rewire and, work that out on its own. It's really amazing in the acute side because when you see somebody like right after a stroke, sometimes I've seen a person where the first time I see them, they aren't talking, able to say anything at all. They're having a hard time, even answering yes or no questions, understanding anything. And then you might go back 2 days later and then they're talking again. And it's, I didn't do anything, right? That was just the brain, the amazing things that the brain can do. So there's that side of it, of course, but then also, I think that people who do go through therapy, to kind of help that process along, it can make a huge difference. And just, helping to get those pathways kind of working again. So.
We'll return to this podcast episode in just a moment, but first I have to ask you, please like, share, and subscribe to the In Good Company podcast on YouTube, Spotify, and Apple Podcasts. It goes a long way to get this episode and others into the feeds of people who want to learn more about general wellness and aging better. And now back to the show. What has been the most challenging case that you resolved? Kind of like a Dr. Gregory House episode. Sherlock Holmes.
Yeah. Off the top of my head, one example I can think of is, and this is where it's like, I mentioned earlier about the swallowing where, you can't know just from watching a person, what's going on the inside. And so, like one example is I went and saw a patient over at the ortho hospital one time actually. And, they were saying that, yeah, man, she's really coughing and having a hard time, with her meals and everything. And I get there and I'm talking to her and, I noticed that she was coughing and clearing her throat, constantly. Everything was making her cough and clear her throat. So even just like, talking was doing that. Every single thing she swallowed, every swallow was making her cough or clear her throat. And, in that instance, and she didn't have any of the, signs of, she didn't have pneumonia or anything like that would suggest like, we're having aspiration. So, in that case, it ended up being, I think we're having some, what it's called laryngeal hypersensitivity. So, I want to say this individual had surgery. And then I think I had gone into her background as well. And she had been having some problems with this for a while, but the surgery just kind of exacerbated it. So basically, the larynx or the voice box, we think of how, that produces our voice. And that's kind of the main thing people would think of. But really I shouldn't say primary, but the biggest thing that the larynx does as well is it also protects the airway, because it sits at the top of the airway. And so it's kind of like the vocal cords, you could think of them as kind of, like the bouncer, into, into the airway, right below the vocal cords is, the trachea and then on down to the lungs. And so that's why, if you do aspirate, you cough. That's your body's way of, getting that out of there. But there are times where, it can kind of go into overdrive and basically, start doing its job too well. So maybe, we're seeing things as a threat that, shouldn't necessarily be a threat, and it's, hypersensitive. So that's also another kind of niche area of speech therapy that a lot of people don't know about is laryngeal hypersensitivity and chronic cough. And that's a big outpatient thing. So it's not something that, you treat as much like on the acute side. But outpatient, that's a huge deal. And so it's kind of just teaching the person about, why this is happening, making sure we're ruling out, we're going to do imaging and see, okay, are we having a swallowing problem? If not, okay, then, we're probably thinking that this is more of a hypersensitivity. And so, yeah.
Interesting. Opposite side of the spectrum. What's the most common thing that you see on a weekly basis?
Yeah.
With patients?
The most common thing, now that I'm in the hospital, now that I'm in the acute side, I would say the most common thing is, post-stroke, swallowing problems, or cognitive problems. I mean, I do so much with swallowing now that's kind of like the first thing that pops up in my head. But the cool thing about it too is that, like I said before, it's such a wide spectrum that, I might see somebody who is, really, really struggling, like even just a tiny sip of water from a spoon, it might send them into a coughing fit, and their oxygen, might be dropping and things. And then, I might go into the next patient's room and, they can, chow down on a whole meal and be totally fine. And I get to be like, okay, great. You can eat. So sometimes you can either be people's favorite person or their least favorite person, depending on what's going on. Yeah.
So let me circle back to cognition, because I think people might be confused exactly, because that seems like a big umbrella. Maybe there's categories that you guys work with and categories you can't work with, I suppose. I don't really know. Yeah. But maybe you could help us understand a little bit more about your role in it and what things you do to help treat.
Yeah, for sure. Cognition is kind of definitely more of an umbrella term, and there are, categories within that. So, that is going to encompass memory, attention or focus. It's going to encompass executive functioning, and that includes a whole bunch of things like, problem solving, attention to detail, kind of organization, stuff like that. Cognition can also include word finding, being able to think of words whenever you're talking to somebody. And so, when it comes to the treatment of it, we're a speech therapist. We don't diagnose things, right? So for a speech therapist is not going to diagnose somebody with like dementia, but we are more so on the side of, okay, we're going to test this. We're going to figure out, what is our baseline? What areas are you having issues with? And then, when it comes to treatment, there's kind of two main things that we can do. So, we can talk to people about strategies. So, what are things that they can do to help themselves in their day-to-day lives? Could be external strategies, things like, using your phone for alarms or calendars, or, a sign that, reminds you to do something. It can also be internal strategies. So that would be things like, repetition, repeating something to yourself that you need to remember, or association, making connections between, two things. That's an example of that would be like if you learn somebody's name and you want to remember their name, it's good to try to make an association to that name. So think about somebody else with that name, or celebrity, or, things like that. So strategies is kind of one side of it. And then also, we do exercises with people. So think like brain exercise, cognitive stimulation. So that can be a lot of different things, and it kind of depends on what the person is struggling with. But in my opinion, I think the most important thing, especially when I think about aging, is just to make sure that you're continuing to, make your brain work, and do things that are challenging to your brain. I feel like a lot of people know that as you age, when you retire, that it's super important to keep your body moving, and to do physical exercise. And, you can think of it's the same way with the cognitive or, mental side of things. So just making sure that, that you're challenging your brain. You're not just sitting down watching TV all day, every day. I always encourage people to, have hobbies, learning new skills is one of the best things you can do for your brain. There's all different types of puzzles, of course, crosswords and, Sudoku and, so just finding things that you enjoy and, being social too, things like that are all, it's very all encompassing when it comes to the brain. It's not like one, you can do this thing or, take this pill or, whatever. It's very, very, it's a lot of little things that you can do, even just eating healthy, taking care of your body, hydration, making sure that you are on, that you're on the right medications. You're not, on, too high of doses or, things like that. It's a lot. So just sitting down with people sometimes and having those conversations of, the things that can impact their memory and thinking. Another thing is anxiety. So, when I was an outpatient, a lot of times, I would have people who, they would have problems with, thinking of a word or remembering something. And then they would start to get really anxious, and that, it doesn't help. Unfortunately, it makes it worse. So sometimes talking through, what are some strategies to kind of manage that anxiety related to it too, can also be really helpful. So it's a lot. It's a wide scope of things that, can be helpful.
Well, you mentioned that you don't technically do, diagnosis, but I'm assuming you have to make referrals if you suspect there's potential dementia or Alzheimer's, that sort of thing.
Yeah, absolutely.
What things do you look for when you're getting ready to make that type of referral?
So if we're talking about dementia specifically, so, typically if a person doesn't have a dementia diagnosis, but there's maybe some signs of that, we're going to probably refer to a neurologist or neuropsychologist. So, some things to look for, of course, are, changes in memory. Something else is that a lot of times the person's awareness of it isn't always great. So their loved ones see this happening, but they don't. And, that can sometimes create problems for people, as I'm sure you guys know. There's a difference between normal aging and abnormal aging. And so a lot of times, the testing that we do is really helpful in kind of helping us determine, when we kind of put you to the test and, thinking from a functional standpoint, is this more of a mild issue that, isn't necessarily impacting things like safety? That's a big thing we look at too, is, the safety side of things. So, if somebody is, especially living alone, or, taking care of themselves or spouse or whatever, and if they're having problems with, medication, organization, they're having problems with, their finances, organizing that, higher level thinking tasks like, cooking, knowing what to do in emergency situations. Those are all questions that, we talk to people about and kind of, assess. So
you mentioned the importance of physical and mental exercise. I'm curious to know, what are some bad habits people should avoid to take care of their throat?
So hydration is huge. A lot of people don't drink enough water. I actually feel like I'm included in that. That's something I need to work on myself. And, I would have patients sometimes who, they drink a lot of like coffee or soda, and, it's okay to have some of those things, but if that's all you're drinking, it's really ultimately dehydrating you. And then the tissues in your throat can, become angry. You can have, increased phlegm or mucus as well. Managing acid reflux is another big one. So a lot of very, very, very common, is acid reflux. And, this is another misconception people have, is that reflux is the same thing as heartburn. And really, heartburn is one symptom of reflux. That's, the thing that I guess people most commonly think of. But there's a ton of other symptoms that can happen. And even, problems with swallowing, voice changes, those can actually be signs of acid reflux, over time. Increased mucus and phlegm is another one. Things like that. So, and then, like I mentioned earlier, the chronic coughing and chronic throat clearing that sometimes people have problems with, can also be a bad habit, that people don't often realize that they're doing. And it kind of becomes this like snowball effect where it's really hard to get out of it because it's like, okay, my throat is irritated. So then I cough or clear my throat and then it's more irritated and it's hard to get out of that. Another one is some people overuse cough drops whenever they're having, and most cough drops have menthol in them, which is actually really drying and irritating over time. There's actually, I know there's been some studies where they've looked at like using cough drops for people who have chronic cough, and they've found that it actually tends to make people cough for longer if you use it long term. I think if it's just like you have a cold and you're using it, for a couple of days, that's not a big deal. But I've had a lot of patients where they're like, yeah, I pop cough drops every day. Like they take them like they're candy. And I'm like, okay, that's not great actually. So that's another one.
Out of all those, what do you think's the worst? Number one culprit for issues.
Worst. I'd have to go with probably the acid reflux, just because acid reflux to me is an issue that is so misunderstood and it's so common, and it causes so many of the issues that we see, with swallowing, voice, it can be really damaging. And I think not a lot of people realize that. They think of it as this just like, nuisance of like, oh man, I get heartburn, so then I take Tums, and but in reality, it can cause a lot of damage. So
what about good habits? Let's go the opposite way. You mentioned mental and physical exercise, but what else could people do at home, maybe as remedies or nutrition or diet, et cetera? I don't want to put words in your mouth. Yeah. But what are some things people can do to take care of their throat at home?
Yeah. So, it's a lot of it is really just kind of the basic things, eating healthy, like I said earlier, hydration, making sure that you're not overusing your voice, not yelling too often or things like that. Even things like weightlifting. Sometimes people that weightlift, they will, like grunt or, kind of bear down with their throat, and that can cause problems. I'm trying to think. I think good habits wise, the biggest thing that comes to mind is hydration. But then, when we go back to the acid reflux side of things, your diet can have a really big impact on that as well. So, things that are overly acidic. So, coffee, tomatoes, spicy food, it's a lot of things that are acidic. I remember when I was an outpatient, I would go over those things with patients a lot. And, people would be like, really? Like, I love these foods. And I'm like, I get it. Me too. So, and it's not necessarily about like, oh, you can't have those things. It's just about being mindful of it, doing it in moderation. I remember I had a patient once who would drink like 2 pots of coffee a day. And I was like, okay, I am not going to tell you to stop drinking coffee cold turkey because that would probably be terrible. But let's try to see if we can slowly kind of cut back on it some. So I would say, managing your acid reflux. And not just with medication. People think about, okay, I take omeprazole or whatever, for acid reflux, which is great. But the dietary side of things, and then, there's certain habits, things like if you eat too late at night, like eating and then laying down, that's not good. Gravity's your friend. So you want to stay upright for, a minimum of 30 minutes. It's better to do like an hour or two of, being upright before you're laying down. You can elevate the head of your bed. So whether that's like if you have one of the fancy beds with the remotes, or, there's special pillows you can get, or just, stacking things up underneath your mattress. There's a lot of things that you can do to help with acid reflux other than just taking medication. So.
Well, I'm definitely guilty with the coffee. I need to cut back. That's for sure.
Yeah.
Hydrate more.
It's easier said than done. That's for sure. And I think it's especially once you start having problems that you can trace back to that, whether it be swallowing issues, voice issues, whatever. I think that's when it's like, okay, if I want to fix this, that's my motivation, is to drink more water and to, just have those healthier habits. Speech pathologists also work with patients who have head and neck cancer. So that can be cancer of the throat. It can be cancer within the mouth, the tongue. And so, we work with patients who have either had, surgery, radiation, both. So a lot of those patients can have problems with swallowing and problems with their speech. So it is, really helpful whenever we can see those patients to, educate them, give them exercises to do, stretches to do, especially with radiation, because the effects of radiation can last for years, actually, and they can worsen over time. They get fibrosis within the neck tissues. And so when those tissues get tight, they don't move as well. And it can cause a lot of problems with swallowing. So we want to really stay on top of that. Like I said, exercises, making sure that they're continuing to swallow, whatever they can. Sometimes people, especially when they're in treatment, will have to get like feeding tubes. But even though they have a feeding tube, the big thing that we would always emphasize to them is keep swallowing. Even if it's, even if you can only do a little bit, it's better than nothing, because you can have atrophy of the swallowing muscles, and that weakness can really make swallowing a lot worse. And that actually goes for any person with swallowing problems. We don't, there's a lot of pros and cons, things that you have to weigh out when we're talking about swallowing issues, with the risks and benefits. But, something that is really important is, that atrophy and making sure people are continuing to swallow, even when we have patients that we keep NPO, nothing by mouth, for, various reasons, normally because of the, aspiration risk. We still want those patients to be swallowing. A lot of times, we'll still have them do ice chips, or, sips of water, because, like I said, the risk of, that atrophy happening can really make things a lot worse. Something else that I forgot to mention is oral care, the importance of oral care. It's huge. So, oral care is, brushing your teeth, your tongue, even if you don't have teeth, even people who wear dentures, or if they don't have their teeth and they don't wear dentures, that's definitely a myth that they don't need to brush and keep their mouth clean. So that's really important. When it comes to avoiding aspiration pneumonia, it's one of the biggest factors that can make a person higher risk, is if they don't keep their mouth clean, because the bacteria in the mouth, when that goes down the wrong way, even if it's not when you're swallowing, even if it's just your saliva, there's always going to be the risk for that. So oral care is very important.
Favorite part of your job?
Okay. I think in general, my favorite part of my job is just, educating patients and their families, and, getting to teach people some of the things that can help them, in their day-to-day lives and can be really functional. I would say on the communication side of things, we talked about the aphasia earlier. That's something that I really enjoy is, helping teach people and show them ways that they can help their loved ones, getting them set up with some of those alternative communication. That is very satisfying to be able to see somebody who, is having a really hard time communicating with their loved ones, to be able to do that. So.
And how can listeners reach you?
If you want to do like an outpatient speech therapy for any of the, stuff we talked about today, I would reach out to your primary care doctor, or, it can also be a specialist. So if you see a neurologist, or anything like that, you can reach out to them and they can get you set up with a referral. That'd probably be the best way to go about it.
And is there anything else you would like to add that we have not asked?
I know you guys have talked to PGO people before, but PGO is a great organization that I'm involved with, and Alex is involved with as well. So if you have any loved ones who have Parkinson's, refer them to the Parkinson's group of the Ozarks. There's lots of amazing classes, support groups, resources. So,
Molly, thank you so much for being on our show today.
Absolutely. Thank you for having me.
If you enjoyed today's conversation, make sure to like and subscribe so you never miss an episode.
And we'd love to stay connected. Follow us on YouTube, Facebook, and on Instagram at In Good Company Elder Care Podcast.
You can also find us on X, formerly known as Twitter, at IGC Pod, and on TikTok at IGC Elder Care Podcast.
Thanks for tuning in to In Good Company. I'm John Ray, and I've been joined by my amazing co-host, Spencer Ernst. Special thanks to our executive producer, Alex Wallace, for helping bring this show to life. Until next time, take care, and remember, you are always in good company.